Kristen and I are gonna talk about two things. I'm gonna introduce the National Center for Human Factors in Healthcare, which is our Human Factors Center. I'm gonna give you the context of where it is, and I'm gonna tell you a couple minutes about the startup of that organization, and then I'm gonna tell you how we've applied it in our organization. Then Kristen's gonna come up and give you more details about the sustainability of the Human Factors Center. And I just want to give you context of where we live. I am either having a user interface design problem. Okay, there we go. Oh, it's just delayed. Let's try that again. Okay. Okay, so MedStar Health, Georgetown University Hospital is part of the MedStar Health system. MedStar Health is the context with which Kristen and I live. So just very quickly, all the numbers are there if you want to download the slides. But it's a 10-hospital system in the DC and Baltimore region, about 300 outpatient sites, $8.5 billion annual revenue, and 35,000 folks. It's a nonprofit organization. And that's all important context, because what happened is in my second year of the K Award, for family reasons, I needed to move to DC. I had developed a small research program in applying human factors in healthcare, and I went to MedStar Health, and all the areas around in a 2-hour radius for family reasons. All the other departments of emergency medicine were kind of like, that's good, little boy, you know, come on, come work your shifts in the ER and you can build your grants and your vision is wonderful. MedStar Health, they said, you know, I had presented a 5-year vision for where I wanted to build the Human Factors Center to. I wanted to have at least one, probably 2 PhD partners, human factors scientists, master's degree, and research assistants. And at MedStar Health, they said, why don't you send us a proposal to say, what would it cost to start with that, and where do you think you'd be in 5 years if we started with that? And what that resulted in, so it's just kind of a leadership moment, I think, in vision, is we now are, Kristen will have a slide later that says 20-plus people. We're being a little bit careful now because it's a grant-funded organization. But we are up to $40 million in funding. We've had as many as 40 people in the organization. We have mentored dozens of really great human factors embedded people. And the idea of this Human Factors Center from the start has been to take human factors, safety scientists, with clinical scientists, both research and operations, and put them together and embed them in a health system to be the research lab. And my background was really, I should be at a psychiatry conference because I need help for this, but I was a safety scientist for 10 years. I did a master's in human factors. I was a paramedic for fun, but I was not in healthcare other than that. And I worked in the aviation and transportation industries, and I was a private pilot. I didn't know anything about healthcare safety. I knew about aviation safety, transportation safety, like high-speed rail and vehicle transportation. I knew about nuclear safety, and I considered myself a safety engineer. And I got a job as a paramedic in the ER and wanted to go to medical school to be an ER doctor. I thought it was a career change. And then I got into healthcare, and the unbelievable thing is that all of these things that were normal to safety engineering in all these other complex high-risk industries were completely unknown to healthcare. And I really, it blew my mind, my head was exploding, and I really should have gotten a psychiatric consult. But that is what started my career, trying to say, I want to marry these things from a research and publication standpoint. And that was the premise of this center. Now, I have since gone on, a lot of what I did included operational consultation in our health system. I've gone on, 6 years ago, I transitioned to leading quality and safety for the health system. I'm the Chief Quality and Safety Officer, and Kristen and Raj Ratwani, her partner, are the two people who are actually leading the center now, and I would say in the years since they took it over, it's more than twice as great as the way I left it to them. But they're very close partners because we integrate a lot of the work operationally. And part of my goal is to tell you about how we do that now. Kristen will come back and tell you more about the Human Factors Center at the end. So I have two goals with the rest. I want to tell you how we apply human factors safety inside our health system, but I'm going to do that in the context of an abbreviated version of a talk I was asked to do a couple years ago by the IHI. They asked me to do a keynote presentation on from the lens of a safety scientist, what we think we're doing wrong. How do we actually get safer in healthcare? Because we have not been getting safer. Well, at least we're not getting safer fast enough, right? And I tried to be humble. Human factors is about inquiry and observation, so I thought it shouldn't just be my lens. So in order to prepare for that, I did a qualitative study where I interviewed 30 safety scientists that were embedded in healthcare. So that my kind of inclusion was they had to have real credentials as safety scientists in different fields, not just human factors, but it was very biased towards human factors because that's more of the world I knew. And they had to have been embedded enough in healthcare that they really understood the domain. And then we also did, for triangulation, we did a separate LinkedIn, calling all safety scientists in healthcare. And that was kind of fun. But we took the 30 interviews and we did a qualitative analysis and we had 5 emerging themes, which did resonate with me. That's why I can call it triangulation. Here they are. First, avoid the conflation of quality and safety. Second, deliberately infuse safety science into the work that we're doing. Third, preempt harm with a proactive focus, because we are all just reacting all the time in our timing, in our resource management, I mean. Prioritize new safety culture drivers. And finally, and I think the hardest but probably the most important, is engage the entire healthcare industry in the systems approach. Because right now, the way we're approaching healthcare safety as a nation is it's only up to the people at the sharp end delivering the care to actually make us safer. We don't have as much partnership as we could from all of our partners. So I'm going to go through this in an abbreviated fashion. I'm only going to focus on a couple, but I want to tell you how safety scientists look at this for the context of this. And I'm not going to be specifically talking about AI, but I think you'll see how this all applies to AI. So first is avoid the conflation of quality and safety competencies. Now, healthcare is different. We can learn from other industries, you'll hear people say, I don't want to hear any more aviation analogies because we're different. Well, we're different, but safety engineering principles apply differently, but they apply. And one way we are different is our product also needs to stay safe. So when Toyota does their Kaizen work on the assembly line, they're worried about the quality of their product. Our product, we're worried about quality of care and keeping them safe. So first you have to understand that when I talk about this difference, to a patient, we think of the IOM definition of quality. Quality includes safety, efficiency, equity, effectiveness, all those things. That's what a patient cares about. But when we approach this, we need to think of it differently because there's different competencies to do it. So what is quality? Quality is the degree of excellence measured against an established benchmark. And what's important is what the patient thinks. The patient would say, how does my care measure up to best practice? And the thing that's great about quality for the people looking at us, like CMS and Leapfrog and is it's measurable. It's really easily measurable. So we can improve quality in 2 ways. We can improve the care that we're giving on those metrics, and we can improve the way that we're documenting it and optimizing the ability to represent the care we're giving. But safety is different. Safety is how do I stay free from harm? Please don't harm me is what the patient says. Health equity should be built into all of this because we should be doing quality of care and safe care in an equitable manner where everyone has fair opportunity to be healthy and receive high quality, safe care. So why does this matter to the context of this discussion is the competencies necessary to do quality are things like Lean Six Sigma, Kaizen, SMART, Plan, Do, Study, Act, industrial engineering, kind of standard industrial engineering things where you have a process, you're trying to get to an outcome, you're trying to engineer the process to be consistent, reduce variation, you use leading metrics. These are the skills our quality people have. But what keeps happening in healthcare is we have people that are good at these things, like they're Lean Six Sigma black belt, and we name them the safety leader. And we forget that we need to train them in competencies around safety. And this really impacts the way as we bring AI in, and we're charged with keeping it safe. Think of the competencies in safety, which are completely different, and make sure that the people that are charged with keeping us safe as we do new things like AI have these competencies, like human factors engineering, complex systems theory, resilience engineering, systems thinking, teamwork training, communication, how to do a good event review, how to do humble inquiry. We could go on, but it's different than Lean Six Sigma. I always chuckle a little bit when I put out a safety leader job description posting, and I get resumes from people who are, their first line in their cover letter is that they're Lean Six Sigma certified. And that's not what we need in safety. Now, am I saying separate this? No, there's lots, including people like me, that are good at both. I think I'm good at both. So I'm not saying they need to be separate people or separate groups or that you need new FTEs, but as we bring AI into healthcare, it is going to be critically important that we do better than we did when we brought EHRs in. We have to design from the start for safety, and the people doing that design for safety have to have the right competencies as they do it. So the second is to deliberately infuse true safety science. In the interest of time, I'll just kind of summarize it, but we have to have people that are experts in this. And this room is perfect. There are so many people with this kind of expertise, and that's what we need to do. We need to learn the lessons of EHR design because we kind of didn't design it well from a safety and usability standpoint to start, and then we've been trying to fix it ever since. We have the opportunity now to understand how AI interfaces from a safe and highly effective usable standpoint and design it right from the start. I think the most important thing, if you think about what we're doing in safety science and infusing it, is understanding the fundamental difference in 3 different major categories of human error. This comes from Rasmussen's and Reason's work, and many of you have heard it, but I want to make the point, skill-based error, which they weren't healthcare people, so they named it badly, because we think of IVs and intubation and central lines. That's not, they don't mean technical skills. Think of it as automation error, things that we do every day. Those are the errors that are most common in healthcare, and those are the errors that are not fixed by things like policy and training and signage and labeling and mindful moments. Skills-based error are the things that we do every day in and day out, so we're impacted by the interface design and the usability. And my favorite example is from a study I did years ago, around the time when I was first referencing Elizabeth's papers, was this. We did a simulation study on defibrillators, and we found that people, when they went to defibrillate, which is a life-changing moment, right? If somebody's in VFib arrest, especially a witnessed arrest, you have minutes to defibrillate them to bring them back to life. Otherwise, you lose their life. And there were errors of people hitting the on button when they meant to hit the shock button that were pretty common. And when you hit the on button, on many defibrillator models at this time, and some still today, it just turns the defibrillator off. So if you think about very simple, basic human factors and error, and understanding human error and designing to mitigate error, that is design malpractice. And to bring the point to you, I'll think about, I don't know where the slide projector is, but oh, it's behind. If I went to this slide projector and I pressed the power button on the slide projector, what would happen?
Are you sure?
It would ask if I'm sure. Do you really want it? And this is any brand of slide projector that you can buy and I've ever seen in the US. If you go and press the power button, it asks you, are you sure you want to turn me off? And that is because the slide projector developer said this is an anticipated use error, not use. This is an anticipated error that our users could make, and we're going to mitigate the adverse event from that. We're going to mitigate that something bad could happen by asking them this. And compare that to a defibrillator, where if you accidentally press the off button, by the way, which says on, just to go, I could talk for an hour about the interface design problems. It's also green and it's solid state. There's all these things that violate basic human factors design standards. And if you press it, it just turns off. Now, here's a defibrillator that should know it's just been charged up, which should be a signal there's probably somebody that's just died that needs to be shocked, right? And it just turns off, and then it takes 3 to 4 minutes to restart. It's a computer. It has to go through all the startup stuff, and then you have to recharge it. That's 30 to 40% chance that that patient will not live, that you've lost, because it's about 10% per minute chance of resuscitation in VFib arrest. So the design of medical devices, EHRs, many things, is based on this presumption, this big fallacy, this false presumption that we will get safer in healthcare by just making sure that the doctors and nurses do it right next time. And be vigilant and be careful and think about what you're doing, rather than designing for safety. And if we don't think about AI design from the start this way, in designing for safety at the very start, we're going to find ourselves in a similar position that we found ourselves with EHR, but it's going to be much more scary. If you don't know what a use error is, you got to read Don Norman's book so you can talk about Norman doors. And this, I show you this slide just so you think of me the rest of your life every time that this happens to you. But we're not psychotic, yet doors do communicate with us as we approach them. And from a human factors lens, everything has a display and a control. The control on the door is obvious. It's a handle. The display on that door is telling your brain when you're in skills-based mode, and we're in skills-based mode when we open doors because we've opened doors since we were kids, right? That's something we don't think about. You don't stop and have a mindful moment as you approach the door and think about how to use it. This door is communicating with you to pull on it, right? It's a pull handle. But do you stop and read the label? This big label in front of your face that's saying push? You never do. And that's because you're operating in skills-based mode. And the next time this happens to you, I want you to think to yourself, this is why we can't fix skills-based errors with signs and labels and training and all this stuff. Now, the great thing about this is this example shows you the perfect design change solution, because this design change solution mitigates in 2 ways. One is it has the proper display, right? It's telling you to push as you approach the door. It's telling you to push. But what's the other mitigation? There's no handle. It's a forcing function. It's by design made it really hard to do the wrong thing. Now, I always joke that we all have somebody on our team that'll put their fingernails in there, but it's really hard to try to open that door. So you've almost essentially eliminated the error without trying to touch the human. We haven't trained the human. We haven't given them a guidebook. We didn't put a policy on the book and have the nursing educator have everybody sign a thing saying that they've been told to have a mindful moment before they get to the door and read the push handle. And if you haven't heard about this example before, I really recommend Don Norman's book, The Design of Everyday Things. It's a beach read. It's fun. It's full of stories. You can read it in 2 days for a weekend. Please get that book. It's really a good basic introduction to human factors in a fun way if you don't already know human factors. The third is preempt harm with focus, preempt our work and harm with proactive focus. This is the way we do it at MedStar Health, and this is where human factors has really been integrated. We try to be really good at reactive work. We communicate with the family. We're open and honest. We do good systems-based event reviews, and we do care for the caregiver. But the money is in the proactive, not the meat. The impact is in proactive. So the first is design for safety. We call that primary safety work. But the middle is, I think, where the real meat is, and that's understanding where the risks and hazards are. Our human factors team really helps us do that, and then once they find the risks and hazards, they help us design out and mitigate the errors as much as we can. So I have 2 more, so I'm gonna skip quickly to prioritizing new safety culture, and I'll do this very quickly. I'll say that if you look around the country, and you look at safety culture surveys, the management and executives all think they have a great safety culture, and the people taking care of patients don't. And this is a real to scale. This is Press Ganey national data to scale. The management is way up there on the left, and everyone else on the right are taking care of patients. So that's less relevant, I think, to this overall story, but I wanted to tell you all 5 points, and I'm just going to focus on the relevant stuff. We've done, for a long time, we've highlighted a case called the Annie story. Please Google Annie and MedStar as your homework and look at this 5-minute video about Annie, who was suspended after an error a decade ago. And it turned out to be an interface design problem on the glucometer, which the company has since changed, but everybody thought it was Annie's fault. She's been on the stage at IHI with an apology to her. She's been at the White House talking about this in the previous administration. And so I just wanted to mention that, safety and culture. So the final thing, before I turn over to Kristen, is I think going to be the hardest and the most important. And here's my aviation analogy for you. For a decade when I was in graduate school, starting with when I was in graduate school doing safety, the lab I worked in did aviation safety and transportation safety, and I became a private pilot at the time and then flew for a decade. And so I have a lot of aviation analogies in my talks and work, and I really believe that even though the industries are very different, the basic principles apply and can help us. So we are different, but it applies. So what aviation has really done is they've taken a systems approach to safety, and this we haven't done in healthcare, and I think this is a challenge that we should meet in AI. And that is that aviation, when NTSB identifies a risk or a hazard, they don't then solve that risk or hazard or mitigate it. They hand it off to an FAA-supported group called the CAST, the Commercial Aviation Safety Group. And that group, I listed everyone there in that group. It's everybody that affects aviation safety. The labor unions like pilots and air traffic controllers, the aircraft manufacturers, even the engine manufacturers and parts distributors, government agencies, the airports, everybody. And the difference in aviation is all of them are harmed when there's a plane crash. And in healthcare, the harm when there's an injury to a patient is obviously the patient and their family first, but then it's the healthcare delivery organization, and there's very little risk beyond that. So we don't have a same shared responsibility approach. In fact, we have laws on the books that antagonize this, like the hold harmless clauses, which are heavy in EHR vendors and in medical device as well. And I think we need to share the accountability and do this together. And that's, I think, as we move into AI, we need to really worry about this. There are already, if you look at the way this is being treated from a regulatory standpoint, there are already formal regulations that say it is up to the healthcare delivery organization to ensure safety of AI is implemented. And our approach to it at MedStar Health has been to say to our partners, we need your partnership in this. You're implementing this all around the country. We're doing it this one time. Don't ask us how we want it. Tell us how you think it's safest. And I think that's a really important approach. Kristen. Whoops. And I have this mirror monitor if you want to use that.
Sure. It just goes on. Okay, thanks. Terry, I don't mean to age you, but it was actually 8 years ago that you shifted to quality and safety. I joined the human factors team in 2017 that summer, and it was that period where there was a shift. And I credit so much of the growth to Raj on the scientific side and thinking about different funding agencies and mechanisms and internal and external partners. And the start was awesome, and then how do we make this bigger and better, which is what I'll talk about. So there's the mission and vision, which I think for a lot of people is just sort of a academic exercise, but I think it was really important to us. You'll hear more about group 3 breakout, but so much discussion about like, what does this look like and who are we and what's our charge within the organization. And so there's a few things here in terms of the vision that we wanted to focus on: the research application and the diffusion of knowledge. We are a big team, but we don't sit on every committee across all 10 hospitals. Like, we're embedded, but our charge is not fix things at MedStar 24/7 every day. We're about 95% funded by grants and contracts. So making sure that research part was really core to our vision. For the mission, we talk about so many things that we could touch, and we decided to prioritize on safety, efficiency, and quality. We do things in provider well-being, we do things in patient experience, but really the focus is on that safety component. And then with the approach, making sure that there's this systems perspective, that we think about the complex interactions, that socio-technical systems, the model that everything is related. So this is my more recent slide. And this actually, it seems like less people, but this is really a success, and I think demonstrates the growth of the human factors team into other teams across the MedStar system. So for example, we had a health equity scientist that sat with the human factors team that then started the MedStar Center for Health Equity Research. Zach Hettinger was our director of, our medical director and director of informatics. That spun out into an entire center of biostatistics, informatics, and data science. And so the growth of this has become new centers and more partners for us to work with that don't necessarily sit within the human factors team anymore. But we do have varied expertise, and I think that's really important for us, that we have tons of people that are trained in human factors, but coming from very different disciplines within that field, and then that we have clinicians that are embedded within our team to make sure that we still have that clinical lens. Some of the things that we prioritize is that expertise. We have 5 PhD level folks that are writing the grants and the contracts, and they're all trained in human factors in industrial engineering. Certainly the younger, more junior folks will take from different disciplines, but we want to make sure that we have that core human factors talent within our team. And then we're able to bring the scientific rigor to whatever we're doing, whether it's wayfinding or predictive analytics or now some AI work. And really one of the most amazing things about MedStar is just the system within which we sit. So 10 hospitals, over 300 outpatient clinics. We continue to grow into the community, and that allows us on the research side to do a lot of work. I can do things in a rural setting. I can do things in an urban setting with pediatric patients, with geriatric patients, and everything in between. Our work has changed slightly over time, but these are really like the core 3 things that we do. And again, applied research is the bulk of that. So that is the grants and contracts that you think about from federal funding, from industry, from foundations, making sure that we are helping with not just the academic research, but a lot of the implementation, intervention type work that is happening across the system, and that we then disseminate that in all of the traditional ways. I'll talk a little bit more about our safety integration, how our team is embedded within different clinical areas for specific initiatives. So we're purchasing new beds, we're looking at infusion pumps, whatever it is that we can bring that human factor systems engineering lens to. And like Terry had mentioned, both reactively, but also a ton of proactive work. And then on the education side, we are connected to Georgetown, and so we teach in a number of different programs there in the School of Health, the School of Medicine, the School of Nursing, the Informatics Center. And then we do workshops, training, guest lectures, all this stuff that to ensure that we are bringing human factors to the people so that they can then apply it themselves. And I think that's a really important part of our mission. Linda, I think yesterday you asked how many hospitals do you have a human factors person sit on your RCA team? And I didn't raise my hand because our team has really worked closely with quality and patient safety. They know human factors. Many of them actually have human factors training. They don't need us to sit on those reviews. And so in ways that you can teach others to be able to do this themselves instead of relying on Ken to sit on every RCA that happens in his hospital. When you look at our research portfolio, yeah, we have about 30 million, 5 or 6 million at any given time. We just crossed over the 400 publication threshold, which we were pretty excited about. Right now, we have 20 active projects, and that is a mix of grants that we are leading, that we are the PIs of, but also working with external partners where we maybe are the site that is supporting that work. We support clinicians across the MedStar system when they need human factors work, particularly some of the qualitative workflow analysis, stakeholder interviews, that sort of thing. And then again, really focusing on the impact. The projects are important, but the dissemination and that diffusion of knowledge is equally as important. A lot of people ask, like, what do you study? How do you decide what you're going to look at? I think we try to prioritize what the areas are based on a few different things. What is the clinical need? A lot of conversations with clinicians, with leaders at MedStar to say, what are you most worried about? What's the thing that's bringing you the most issues? Looking at adverse events that have happened, but making sure we're prioritizing things that people care about, that our institution cares about. But we have to be realistic and look at where the funding is coming from as well. So big pushes into the maternal health space, into diagnostic safety, into telemedicine. I don't know that any of us projected that that's where we would go, but that's the things that the industry was excited about, and then we found ways to make that exciting for us as well, and those are some of our biggest project areas right now. When we hire new investigators, I don't think we've ever had a spot of like, we need someone with this expertise. We allow the investigators to pursue whatever their area of interest is in that human factor systems engineering element. So we have one scientist focused on AI work, another work is focused on teamwork and communication, medication safety, diagnostic safety. We allow each person to pursue what they are excited about, because anyone in the grant world knows that churn is really hard. It's very stressful, and so you want to make sure it's a thing that they really care about, because they're going to be pursuing that for the next decade or so. And then thinking about what our competitive advantage is, what are the strengths that MedStar brings that would make us more competitive. Here's just a sample of some projects I wanted to include. The Pennsylvania State Authority, you heard from Chris yesterday. This was a contract to help support 6 million reports, I think you said. That's like unmanageable for anyone to review all of those. And so our team came in to help with a few issues strategically to do that aggregate analysis and provide some recommendations. We want to keep our portfolio diversified in terms of funding and not rely on any one funding source. And so one of our scientists goes after money locally in DC and has a really strong track record with the Department of Behavioral Health for work on maternal morbidity, mortality, and this specifically was screening for substance use disorder in pregnant and parenting individuals in the DC area. The last one I wanted to highlight is our ARC-funded Patient Partner Diagnostic Center of Excellence, one of the 10 ARC-funded diagnostic centers, and ours is really focused on the patient perspective through the diagnostic journey, and giving them the tools and language and know-how to empower the patients and advocate for themselves in that diagnostic process. So that's the research side. On the safety side, there's a ton of things that small team is doing. And really, it's at the request of leaders across the system. I think that's probably like a week to week, month to month. Here's this new thing that we found. Can you come help? And so some of the areas where they have had some major impact in capacity and transfers and digital transformation, patient experience, health equity, and pharmacy. But as you can see, they're touching a ton of different departments. That team is able to deliver a lot of sort of quick solutions. Some of our grants are 4 or 5 years where we're working through, much longer lead up and time frame for us to deliver a product. A lot of these consults are very quick, a few weeks, a few months turnaround. Some of the things they're delivering, user interface design recommendations, some workflow analysis, education, device usability, a ton of impact that they're able to have on the clinical side. Just as an example, some of the more recent projects, looking at how patients use the patient portal and trying to understand when we bring in some AI tools, what are the questions that patients are often asking about? How can we prioritize AI to be able to respond to them? We're still doing some medical device product evaluation things, so they were able to standardize some of the products across the MedStar system. I thought this was interesting that there were 20 different central venous kit models across MedStar, and they were able to reduce that down to 5 and standardize them across the EDs. And a lot of our clinicians do work at multiple sites, and so you can imagine it's important that things feel and look the same no matter where they're practicing. And then something that seems like so simple is wayfinding. And I know, like, I was in a hospital the other day, and like trying to get from the front door to wherever you're going can feel impossible, and there's 10 different elevators. And so we've done a lot of work to support wayfinding, making sure that it's easy for both patients and providers to navigate physically within the building. And then lastly is our education, again, building capacity across multiple levels of learners. More formally, we do have the partnership with Georgetown, and so we have an executive master's in clinical quality, safety, and leadership, where there's a human factors track that Terry and Raj teach in. I direct the capstone. That is mostly clinician leaders, folks in patient safety and quality that want to learn more and have more of that scientific rigor, the academic language. And we are working on a human factors certificate, which would just be a 3-course program instead of a 16-month program. We have been putting together a packet to start a master's in human factors in healthcare, which will be a unique degree focused on human factors, but specifically in healthcare. And then we do a lot of different workshops and trainings. I will point out one of the ones that I am most excited about, which is not MedStar specific, but in support of a patient safety organization out of Long Island. We recently did training with patients and patient advocates and caregivers. And you just realize how unprepared we have made the public and how to navigate the healthcare system, and just bringing together patients and allowing them to ask questions, giving them the language to advocate for themselves has been very rewarding. So I'll end with sustainability and scale, which I think for anyone that is thinking about building a human factors center, an AI center, what does this look like? One of the most important things I think is for us to continue to demonstrate our value, and we do this in a number of ways. Those safety integrations, those consults, what have we actually produced, and are we making a difference? On the scientific side, of course, we look at things like funding and publications, but also what was that impact? Are we doing something that then changed practice at MedStar or elsewhere? Sharing information broadly, I think there are still people in this field that hold things very tight. That they made this thing, and why would they share it? And I think we feel the exact opposite. There are too many problems for all of us to solve to feel like we're not willing to share anything that we've built. And I'm sure Terry does this too. Like every week somebody will call and say, I have this problem, and we'll just brainstorm how they might be able to address it. And we don't need to be on your grant, and we don't need to be on, that's nice, but that's not a requirement for us to partner with you. I can't think of a single grant where we don't have a partner. We work with Ken, we work with everybody because it makes the work better and bigger and richer. If I can do something at MedStar, but I can also do it at MUSC, or I can do it at OHSU or wherever, it makes the work more important. And so we have tons of partners, both internally and externally. And then making sure that we're looking at resources for growth. Do we have human factors programs that we're tied to where we can bring in new talent? Do we have seed funding? You don't get the R01 on your first try. You need that pilot work to be able to show that you have success in that area. And so can we give seed funding to our early investigators to allow them to grow and develop new areas of research? And then the last piece is scale. And I'll actually start at the bottom here, which is right-sizing your vision. There was a time, probably 6 or 7 years ago, where we had so many grants and we just felt like we're doing everything right, we're winning all the things, and we had to have a very honest conversation about what we wanted the center to look like, because we probably could have doubled in size, but is that what we wanted? And now you're adding sort of extra stress and pressure to continue to bring in money to maintain a team of that size. We feel like 20 is a really good number to have a good impact, to still have that team camaraderie. Everyone's on everybody else's projects. We don't have like set teams that only work together. And so for your own vision, what does this look like? It doesn't need to be, a massive center that continues to grow. Maybe you just need 2 or 3 people in this area. I think also for scale is to make sure that you're not just doing the big challenging problems, but you're embedding human factors into the standard processes, that you're not just called on for the big special projects, but you're there to help for anything along the way. We do our best to measure what matters, and making sure that we have both the data, but also the stories and the narrative to put behind it. And then again, making sure that we're infusing this across the organization. So I think for the future of human factors, and when we think about AI, and a lot of this actually came out of that breakout group from yesterday, what is the selling point for anyone that wants to start a center like this? And we were talking about for safety and human factors, I know the arguments. I know that we're going to save lives. I know we're going to reduce the legal lawsuits and the complaints. What does it look like for AI? And so for us collectively, I think to be able to articulate what is the risk that we're facing if we don't integrate human factors? Is it about accelerating the adoption? Is it about adverse events that might happen? How can we deliver value and drive strategy? And maybe for your hospital, it's really about talent and differentiating yourselves, that you want to be this brand new human factors AI center, and that's an okay reason as well. I think trust is the currency of adoption. When we think about patients, a lot of the work that we're doing is how do we communicate to patients that we're using AI in a way that they are okay with that we're being transparent. But I think for providers as well, that they feel like they're a part of this process. And then lastly is operationalizing the work. We never want to be a nice to have for all the human factors people in the room. I'm sure you've also been called in at the very end of a project and they want you to like sprinkle that human factors pixie dust or just sign off like, looks great. But we want to be at the table from the very beginning. And I do think that this is the bridge across all of the things that we think about, the technical, the clinical, the cultural, the ethical domains. And maybe there's a time for some questions.
Well, speaking as a person who's written grants and done clinical work and tried to organize things, this is breathtaking. This is absolutely breathtaking what you've done. So we have time for a few questions. Tim will bring the microphone to you if you raise your hand.
Terry, you want to come back up?
Well, just acknowledging the conflict of interest. I was affiliated with you guys as an advisor for a while, and honestly, now probably a competitor, and jealous is crazy. So obviously, it's amazing, amazing, amazing what you're doing. We're all of us are in trouble with funding, and I love how you're talking about like the DC Department of Health. We've also been thinking about like state funding and things like that. How do you think we can create a new home nationally for funding? And this is obviously not an easy question, but I was just curious if, I'm thinking about DARPA, ARPA-H. I don't know. Who do we get to fund us now?
Yeah, I think we've all been in that stressful pivot for the past month or two. And the answer is not, this is one answer, but go to foundations, because all of us are now going to foundations or there was already limited money. So I think it's being really creative about the opportunities that do still exist. And I think you're right. The ARPA-H is the DOD funding. I think it's about increasing our strategic partnerships with industry. What can we do to make ourselves collectively at an advantage? I know for us, we're going after things that we typically would not have gone after before, like quality improvement level type projects. I'm partnering with people across the system that I probably wouldn't have before, so trying to find sort of the positive things out of it. I also am not panicking because I don't know what tomorrow brings, and every day feels different, and I think a lot of us are just waiting for the dust to settle, and then we'll decide whether there is still federal funding to go after or not.
Yeah, I'll just add, traditionally, I think, was it 60% ARC, our funding overall? It was a really heavy ARC funding over the time. But one other thing I'll just say that some centers may want to consider if you're considering starting a center. The FDA does require human factors analysis with usability in the 510K approval process for medical devices. And for about 6 or 8 years, I guess I don't have my years right, but we had a small business in that. We were a usability consultant, because over time, the FDA has increasingly required that the subjects in those usability studies be people that are qualified to use the device. So if it's an infusion device, it has to be an ICU nurse, not some office worker, which is what used to happen. And it is a good way to generate revenue to support outside of grants that one could consider. At the end, we just decided it was very distracting for us. It became a big focus, and so we decided to stop doing it, but it is a revenue opportunity.
Ken, thank you. You're the first person I've ever heard who recognizes the skin in the game problem between medicine and transportation. And you know, economists have a term for this called moral hazard. I have no skin in the game if I make a mistake on your wife or mother's CT scan. And I think that distinction is really important. And, you know, when I'm on a long flight and I'm getting a little woozy and I'm missing calls from ATC, and then it's time to land, an interesting thing happens, and that is my adrenal glands get this squeeze. And I can feel this physiologic awakening within me because all of these hard, unforgiving things on the ground are getting closer and closer. And you know, for Elizabeth and some of the other human factors people in the room, you know, how do we simulate that, or how do we replicate that at 3 p.m. on my 35th study I'm reading? I don't have an answer for that,
Yeah.
but I think it's an interesting difference between the transportation and medical realms.
I'm glad you brought that up, and I'll answer it with 2 things. I think it is a difference in something when you think about radiology, but I will say there are also some similarities, and I do reject the idea that sometimes you'll hear people say, oh, it's different because the pilot goes down with the plane, so they're more worried. You know, I think we all know clinicians that are taking care of patients are deeply worried about their patients. And I can tell you as an emergency physician, when a patient starts spiraling in front of me and I'm not really sure what's happening, my heart rate is higher than when I'm having a bad landing. Not that I was ever in a commercial position, but there is, in some settings in healthcare, like the ICU doctor, the anesthesiologist with a tough intubation, the emergency physician with a spiraling patient, there is that adrenaline surge. So there are, as in everything when we talk about, there are similarities and differences.
One more question?
Thank you for the presentation. We talked about the funding, which was coming a lot from grants. How far you think you are from the fact that the MedStar leadership think the impact is so important that they self-fund this? Like they have a finance department and they have a human factor for that transformation that needs to happen.
Well, we're there. I mean, we have, Kristen alluded to this, but a large number of our team members inside our hospitals and health system and safety, et cetera, have grown from the Human Factors Center. There are many. And I think that right now, if you think about it, like we're 15 years in on this center, and MedStar Health continues to fund a number of FTEs. So we have it's a soft funding organization. We have more than 20 people, but it's not 100% funding to every single one of them. So I'll just tell you the secret to this. For those of you thinking about doing something like this, you have to have highly credentialed people who are great and smart, but they also have to be like a preacher. They have to be able to get in a room and in an elevator speech, they have to convince people immediately of the value of it. And that's been our magic. If we have had people like Kristen and Raj and people that when they are in the room, people listen. And there are other great scientists out there in human factors that don't have that quality. So you need both. Not you, Ken. You have that quality. He raised his hand. So you need both. If you want to bring a human factors scientist in, you really they have to inspire people, and that's how you get the leadership on board.
Yeah, and I don't think we should expect that the leadership of the entire hospital would totally understand the nuances of this, where we've had really great successes within specific departments, where we add a significant amount of value and it makes sense. So within telehealth, we've done a tremendous amount of work, and that's become a really collaborative partnership. And so there's an MOU with funds that come to our department, and provider well-being for us to support some of the EHR audit log kind of work. So I think to find the strategic partners that have money in the budget that they can then support is like the practical approach, I think.
And human factors is a cost center. When people want to bring them in for a big project, there is a transfer of funds within the
Yeah.
organization. So, okay, thank you.
Thank you so much. Very inspirational. We certainly want to try to walk down this road at Penn State Health. So we've reached our first break. We were a little behind schedule, but we'll catch up later. I've learned not to worry too much about that. Enjoy a good 15 minutes or 20 minutes, and then we'll reconvene. I would remind you that our sponsors have some exhibit tables. You can chat with them. Siemens Healthineers also has Snickers bars. They're not made by Hershey, but, you know, there's a shortcut through the back door to the traditions room. Thank you very much.